One of my favorites from the classic breast surgeon, yourself, is my patient just had a lumpectomy and a sentinel lymph node biopsy. Why would they need to go to rehabilitation? Okay. And that's a fair question. But again, that's a surgeon that's thinking again in a very siloed, targeted approach, like this person's just being affected by surgery. Okay.
Yep.
So, and honestly, a lot of people who even have a mastectomy or a partial mastectomy with sentinel lymph node, they do come out and say, I'm completely pain-free. I have zero limitations in my range of motion. don't have any cording. Okay. And that's fantastic. All right. So even though they've had just a lumpectomy and just a sentinel lymph node biopsy, there are still people will, a good 20% plus will have perhaps cording, limited range of motion, or pain at the axilla, the arm, or the chest. But beyond that, again, if somebody is going to have chemotherapy, all right, we know that starting a exercise prescription before the chemo starts, all right, and then following that exercise prescription during chemotherapy and after the chemotherapy. So they're going to be exposed to that. So we want to get them on that programming right away. And again, somebody who has had a partial mastectomy will most likely be exposed to radiation. So now we're adding in the other evidence of fatigue, possible fibrosis and scarring, decreased range of motion and pain, all those things. But even if it isn't your medical modality that potentially might create these issues of musculoskeletal, cardiopulmonary, or functional deficits, send them anyway, because it's one of the few areas of physical therapy where we can actually be proactive. Okay, what I do now can decrease the amount of aromatase inhibitor pain. What we do now can decrease the loss of neck range of motion for head and neck, radiation. What you do preoperatively for somebody with prostate cancer can impact postoperative incontinence. So it's not just what you do, it's the entire package. That's why we like to get people perioperatively, but no matter who you are in medical oncology or what you do, please get your patients, because again, that's that really broad package that we need to be treating. All right, and again, they might be exposed to aromatase inhibitors, and again, will benefit from long-term exercise prescriptions.
Yeah, and just to throw another comment in here, in the early days, we simply made an incision in the skin, plucked the cancer out and closed it up. There's a lot more to contemporary breast cancer surgery now. So this slide that you've got up here, Leslie, is really germane, really, really important, okay?
All right. We all look at the world, especially a patient, through the eyes of our own profession. So here's a gentleman that has a B-cell lymphoma, or had a B-cell lymphoma, in his left femur. So from a rehabilitation standpoint, he postoperatively, obviously he had a surgical rotting. So postoperatively, the man had a lot of pain. He did not want to step on that leg again because it broke on him. That's how he found out he had lymphoma, when his femur broke. Right. Then that was radiated. So his skin over the anterior thigh became so thick and short that he didn't have enough skin extensibility to bend his knee. So his knee didn't work well. He couldn't stand. He had a horrific gait. He couldn't weight bear. And then throw on top of chemotherapy. So then he developed significant fatigue and significant neuropathy. So now this man with this leg now can't feel anything from the knees down. He gets done with cancer treatment and gets his little, rings the bell and says, I'm cancer free, or certainly in remission. But he said, I can't go back to work. I can't drive. I can't put my pants on without falling over or sitting down. I can't function like this. He had a wife and kids, and he's like, I need to be who I was before. So again, for him, once he was cleared of postoperative restrictions, we began strengthening the quad hamstring glutes. We were able to, again, we can't change the actual fibrosis of the skin, but we can certainly lengthen and soften that tissue enough where he could then bend that knee to almost back to 115 degrees again. So his gait normalized, worked a lot on weight bearing with him. Got him on a good, strong strengthening program for arms and legs to help, and aerobics to help decrease his fatigue that he was feeling. And then lastly, again, we can't change the amount of sensation that he feels, but you can see him in this picture standing on a balance disc. Work on improving proprioception, work on ankle strength, foot response, visual feedback to improve his overall function with the neuropathy that he does and probably will have long term. And then here we have from an oncology perspective, here's a 31-year-old female. You can see at the posterior distal femur, she's got a pretty ugly looking sarcoma. So she had neoadjuvant chemo using cisplatin and adriamycin. and then had a surgical prosthetic replacement, which I will show you in a second because it's pretty profound, and then palliative radiation to that femur. And then unfortunately, shortly after her adjuvant treatment, she did have a recurrence to her abdomen and lung.
Oh, wow.
So here is that leg. All right. So how do you take this now and throw in neuropathy, throw in systemic weakness, throw in fatigue, get this back online again? And then this is Emily. And again, like I said, at this point, she had metastatic disease, so was given about 2 years to live. But again, she's like, okay, I need to walk. I need to get to the second floor of my apartment. I lived on, I need to drive. I need to get back to work, and I need to get to Mexico. And I want to go somewhere every weekend. If I have, 31-year-old with 2 years to live, she said, I need to rock this. So again, weight bearing, range of motion of that knee, strengthening of the leg. And then again, you can't forget about, the gait training, functional training, getting her up and down the stairs safely in and out of a car. She's like, why am I strengthening my arms? It's my leg. And I'm like, do you have fatigue? And she's, yeah, it's crushing. And I said, you need to be exercising your entire body. Do you need to use crutches for the rest of your life? Probably. You need to have strong arms. So again, it's seeing that whole overview of that patient and providing care that addresses every functional need that they may have, or musculoskeletal, cardiopulmonary, or an integumentary deficit that happens as a result of the cancer or the cancer treatment.
These are two, what I call spectacular grand slam examples of the need for your service. Now, let's just focus on the exercise part. Do you, as a physical therapist, create the exercise prescription, and then do you have an exercise specialist who then helps with implementing, or how does it work in your program, or how might it work elsewhere, the exercise part?
There are a lot of different options. And again, every community is going to be different on what they have available to them. Sure. So somebody needs to do it. Yep. So whoever gets their hands on the patient first needs to get an exercise prescription. Typically in cancer care, it's going to be the rehab therapist. So I will encourage my patients, even if they're still in cancer care, even if they're under my care, if they can independently exercise, I want them to get out in the community, either do it at home or hire a personal trainer or hire somebody to come into the home to help them carry on. Okay. So it really depends on how much level of care does this person need that kind of addresses their level of, they can go off and I don't even need them. They don't even need to hire anybody. They're so independent and they're good. Where somebody may, I'm still maybe working on abdominal strength or working on tissue fibrosis or cording, but there's no reason they can't go and work out at the gym or work out with their trainer. Sure. Okay. And then if either I or the exercise specialist says, you know what, I need to talk to your trainer or have your trainer call me because there's a couple of things that might need to be adapted. But hopefully we can all work together. Again, whatever your community has, whatever your patient has available to them. But again, I work in an area where people don't have access to this. They certainly most of my patients couldn't afford something like that. So there's always ways to find ways to help your patient either under your care and outside in the community.
All right. Another question I've got for you, particularly these two last cases you presented, they're so spectacular. Are nutritionists part of your team?
But where we've partnered with them is our folks either with metastatic disease or that have cachexia from a GI surgery, end-stage disease, liver disease, is when we started doing this, I'm thinking, because the data, the evidence says that exercising actually can slow cachexia or reverse some of that protein degradation that happens. Yep. So when we started doing that, I thought, oh my God, my dietitians are just going to rip my head off because now I'm burning calories. But they said, wow, when you get a patient with cachexia or who's really, really sick and can't eat or has no appetite, and you get them stronger, first of all, they feel better. They can stand longer. If somebody can stand for 10 minutes, they can actually make themselves a meal. If they can walk 30 or 40 yards, they can actually get in the car and feel good enough to go through a drive-through. Or they can have, and if they are moving more, they sleep better. If they sleep better, their appetite's better. If they move better, their appetite's better. So it is you can't silo these things. They all impact each other. So that's one of the common ways that we'll work with dietitians. And let's just wrap up for benefits to the patient from seeing a physical therapist, again, either one time only or once a week or once every 3 months, whatever the patient needs is, again, this is all evidence-based. Quality of life will go up because their pain and fatigue and limitations go down. There's also a substantial evidence that patients will live longer. Now, we don't know exactly why, whether it's the exercise, is affecting the actual biology of the cancer, or is it just because we're keeping the ejection fraction higher, patient's performance status is better, so they get more options for chemotherapy, or they can stay on their chemotherapy longer. But even with glioblastomas, people with glioblastoma that walk daily live longer than those who don't. We know that overall survival for people with cancer who exercise is higher than people with cancer that don't exercise. And again, whether that's, again, affecting insulin or body mass index or abdominal fat or overall function, activity tolerance, they fall less often, they don't go back to the hospital as often. But we know that that's a fact. And then with colon cancer and breast cancer survivors, we know that actual exercise decreases risk of recurrence. And again, so when you're talking about compliance with your patients, yes, they're going to need support. Yes, they're going to need education and assistance. But boy, if you throw this out to people, compliance is typically not a problem for us in cancer rehab. Because again, they're going to have less fatigue and pain and weakness. They're going to lose less, and they're going to regain it faster. From a medical oncology side, we're going to maximize cardiopulmonary function, either help people maintain or improve their BMI so they don't either gain too much or they don't lose too much. And again, people are just going to recover so much more quickly post-treatment. It's just less physically expensive and financially expensive for both the healthcare system and the patient. So it's a win-win all around.
Yeah, absolutely. And there's hard data that you have fewer visits back to the ER, you have fewer readmissions, you've got fewer this, that, and so there's actually huge cost savings to the overall health system. So
yeah, we'll be talking about you know, as oncology moves more towards value-based care, we'll be talking about benefits to the health system itself.
Well, Leslie, that was an absolutely fantastic overview of the problem, the background, and all those sorts of things. And what I'm hoping for is we're going to do a future broadcast that's going to talk about how we fix the problem. And I'm also assuming that what we're going to do in a future broadcast is to come up with why healthcare administrators, and particularly cancer center administrators, ought to be paying really close attention to what you've been talking about here, and why it's really important for them to embrace the models and things we've talked about. Is that a fair lead-in, a fair segue to our next broadcast?
Yeah, I think that's a very good segue, because when you start talking about value-based care and cost of care, when I start talking about decreased length of stay, decreased readmissions, decreased ED visits, fewer falls at home, all of a sudden their ears start to perk up, because a physical therapist can impact those things. So I'm happy to talk about it.
Okay, well, listen, from Milwaukee, Wisconsin, from Southern California, we want to wish everybody all the best. We want to remind everybody, stay safe, and we look forward to joining you again in the near future. Thanks so very much for participating with us in this broadcast.
Thanks, Dr. Harness.